Well, hello everyone, and thanks Andel for the wonderful introduction. And wow, this is great. You are going to have an amazing experience at this conference, and I want to express my appreciation to some of the people that I know you'll be hearing more from, Lisa and Daryl and Eleanor and Leslie and all of the people who are here, who are leaders of KGH, in convening this forum of energy and thought and creativity and communication that you've all come to participate in. I can guarantee in the structure of this time that you're going to have here, this is not going to be a passive experience of you receiving information. This is a sharing process. This is a connection. This is an exchange. And what I hope to do tonight is at least provoke some thoughts with you about things that you can be contemplating to fuel your energy and passion as we work together over the next day or so. As Andel told you, I'm a member of the Board of Directors of the Institute for Patient and Family-Centered Care, which is located in Bethesda, Maryland, and we put on seminars, and folks from KGH in North York and many other places have been to our seminars. We put on international conferences on patient and family-centered care, and I want to mention that the next one will be in August of 2014 in Vancouver, and we do a lot of work. But you know what? What really makes patient and family-centered care happen is what happens in communities, in provinces, in states, in places all over this country and the world, and I just so admire what is going on here. So we're going to talk about patient and family-centered care from principles to practice. Now, the first problem starts here for a guy coming from the States. Centered. C-E-N-T-R-E-D, C-E-N-T-E-R-E-D. Which one is it? So I'm going to say centered in both languages. And some of the slides, if I'm referencing Canada, will be R-E-D. And some of the slides, if I'm referencing things that are going on in the States, will be E-R-E-D. And the pronunciation, the nuances may be something that you pick up, but that's about it, okay? You know, one of the great things about traveling is you get to learn. You get to learn what's going on. And KGH's 2015 strategy is one of the more creative documents that I've had a chance to see. And of course, the aim here at KGH, our aim is outstanding care, always, really thoughtfully put. But one of the things that I like about this strategy is what it says about our value to others. We are a community of people dedicated to transforming the experience of our patients and families through innovative and collaborative approaches to care, knowledge and leadership. It's that community that we're here to talk about. It's how do you bring people together? How do you create a culture of collaboration that enhances the experience of care? That's really the essence of what we're talking about. Guiding principles and strategic directions then flow from that, for that organization. And I know there are people here from many organizations. You have vision too. You have missions too. And we're going to talk some about how those missions can express and convey ideas of partnership and collaboration. Patient and family-centered care provides the framework and strategies for improving quality, safety, and the experience of care. That's what we're here to talk about. How do we get better? How do we enhance quality? How do we make our care safer? How is it an experience that is really one that is positive for everyone who comes through your doors of your hospital, your clinic, or your community center? When we talk about patient and family-centered care, we're talking about an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients, and families. Mark those words, mutually beneficial partnerships. We all get better. We all do better. The jobs for healthcare professionals are more satisfying, and the outcomes are more successful when we are collaborating. The experience for patients and families is better as well. Mutually beneficial partnerships. And these are the principles of patient and family-centered care that really underline what we're talking about. First, it's that people are treated with respect and dignity. Now, one of these days, I'm going to make $1 million, and I'm going to make $1 million because I am going to successfully invent a dignitometer. And we are going to be able to get serum dignity levels or, respect titers on everybody who comes through the door. And then we won't have to figure it out any other way. We'll just grab a specimen and we'll know. But really, the only way to know whether people are treated with respect and dignity is to ask them, is to be a partner with them, is to see that are they experiencing that. Now that doesn't mean that every professional here, every professional you work with doesn't have respect for patients, isn't interested in the dignity of patients. They're desperately interested in that. But do people experience that? Is that unequivocal in the way that they get care? Healthcare providers communicate and share complete and unbiased information with patients and families in ways that are affirming and useful. We all share information all the time. We have to, we should, we must. So we do. But is it in ways that are affirming and useful? Is it news you can use? Does it make people as an outcome parameter that you need to consider? Does it mean that the information that somebody has received now allows them to go on and live their lives with greater health and greater personal satisfaction? Individuals and families build on their strengths through participation in experiences that enhance control and independence. Now, I don't know about you, but when I was in healthcare training, I learned more that healthcare was supposed to be kind of like a play. The patient was just supposed to lay there, and then we came in and did our thing for them, and then they left grateful. And that was the way that I understood healthcare was supposed to go. I didn't realize it was supposed to be an active participation sport. And that went on, that if that happened, that actually improves outcomes. So that's what we're talking about, active participation. And finally, collaboration among patients, families, and providers occurs in policy and program development, professional education, as well as the delivery of care. We'll talk a lot about the delivery of care. We'll talk a lot about what happens in the clinic or at the bedside. But we're also talking about the policy and practice level, and we're talking about professional education. Those are the principles that we're talking about. Why do we need to do this? Well, go talk to people about healthcare. They don't always have nice things to say. I call this the Thanksgiving test. Thanksgiving, I know, one date here, another date there, but it's still the same. Families getting together. You're in healthcare. What do they talk to you about? They talk to you about their healthcare experiences. And what do they have to say? It's not always good. It's not always good. And if we're in the healthcare biz, we have this tendency to kind of, well, they probably didn't understand, or gosh, I think it must have been this or that or something. We kind of tend to excuse it. But if you really sit and listen to what people have to say when they tell you about what their healthcare experiences are, sometimes it's kind of scary. Sometimes it's not so good. Those are the issues that are going on in healthcare. This was a 1996 study. Guess what? It's not all that much better today. And that costs. There are costs of not having good quality. There are costs of errors. There are costs of infections and poor communication. There are costs to not doing things as well as we can if we truly are partnering. High above the hushed crowd, Rex tried to remain focused. Still, he couldn't shake one nagging thought. He was an old dog, and this was a new trick. There are a lot of people who think that we have an old dog healthcare system in North America, that we can't make change in the culture of how we deliver care. But I want to tell you, go to KGH or go to North York or go to many of the places around the country, Georgia Regents, who you're going to hear from. Go to many of those places. That is changing It's a new day. And the newness is the energy that is put in by the collaboration with patients and families. In the US, the real groundwork for change came from the Institute of Medicine, one of the most respected organizations really across North America in helping think through healthcare. And so in 1999, they put out a famous study called To Err is Human that really unmasked the issue of patient safety. And then in 2001, followed it up with Crossing the Quality Chasm, challenging a new thought set about what do we mean for quality in the 21st century. What should we be thinking about? And the IOM talked about safety, and patient-centeredness is really being the base of effective, efficient, timely, and equitable care. And they identified these principles for quality. They said that we should expect more than just excellence in biomedical care, that quality means more than that. Quality means that care is based on continuous, healing relationships. It is about relationships. Healthcare is a human transaction, and so relationships are important. And it was great to see them talk about healing. That doesn't mean curing. We can't cure everyone all the time. But we can aspire to help people get to the highest level of health that they can attain. That's healing. And then it was about continuity. Now, I'm a family doctor, and I deliver babies and take care of old folks and do hospital care and do the office care and get to teach and do a lot of fun things that I really enjoy. So continuity, it's all about that. But you know what? Sometimes I'm in Canada. And so no one is going to be that 24/7 continuity, one practitioner. So what did the IOM mean by continuous? It means continuous regardless of who's there. It means across your entire system. It means shift to shift, nurse to nurse on a hospital unit. It means visit to visit in a clinic. Or it means if you see the primary care doctor and the specialty care doctor, you're getting a comparable level of collaboration that is supporting a healing relationship. That continuity is harder to do. That continuity means that what I do is important to what you do, and what you do, and what you do. And if you want to be that great patient and family-centered practitioner, that depends on what happened on the previous shift and the next shift. It doesn't work for you to go into a room and say, "Hi, I'm patient and family-centered. I've been to a conference. I can tell you that I am." When on the shift before, it didn't feel that way, and on the shift afterwards, it doesn't. That just doesn't work. That's what continuity means. It means we're all in the game together. Care is customized according to patient needs and values, with the patient as the source of control. That's a scary notion to some folks. The patient as the source of control. But it is, in fact, the patient who chooses how are they going to handle their health, and what does this mean to them, the advice that we're giving. Knowledge is shared, information flows freely. We've talked about that. Decision making is evidence-based. And of course, evidence-based medicine is exceedingly important in everything we do. But every clinician here knows we don't have great evidence about everything. We don't have a perfect randomized, double-blind, controlled trial for every possible situation we come up with. So the flip side of having evidence-based decision-making is also having skills in sharing uncertainty. What are we going to do in the face of the unknown or the uncertain? How do you want to process this? What information will help you in a decision that's not so obvious and evidence-based to do your best? That's something we all have to own as healthcare professionals. Safety is a system property. It's hardwired in what we do. Transparency is necessary. Everybody knows how things work. Needs are anticipated. We're proactive. Waste is decreased. We are resource prudent and thoughtful, because that creates more resources for all of us to use. And cooperation among clinicians is a priority. It's not just a nicety. It's not just I'll send you a note from the chart, or you can read it here or see it there. It is a priority. It is key. How do we work together in the culture of healthcare that we're a part of. The Institute of Medicine gave that report in 2001. It's continued beyond that, just put out a report called Best Care at Lower Cost, The Path to Continuously Learning Healthcare in America, and among its key points involve patients and families in decisions regarding health and healthcare tailored to fit their preferences. It talks about a learning system, healthcare system as one in which patient needs and perspectives are factored into the design of healthcare processes and the use of technology and the training of clinicians, just like we're talking about today. The IOM continues to recognize when patients, their families, and other caregivers and the public are full active participants in care, health, the experience of care, and economic outcomes can be substantially improved. And when I read KGH's strategic plan, I thought about this learning healthcare organization that the IOM envisioned, which says it's anchored on patient needs and perspectives and promotes, doesn't just invite or ask or accept, promotes the inclusion of patients, families, and other caregivers as vital members of the continuous learning team. In the US, we talk about this as the triple aim. Better health, meaning better health for individuals and populations. Better care, meaning the experience of care is better. Lower cost. Don Berwick, well known as the former leader of the Institute for Healthcare Improvement and also the former director of the Centers for Medicaid Services in the U.S., said the most direct route to the triple aim is via patient and family-centered care in its fullest form. And so we talk about this in the U.S. in lots of ways, including in primary care, where we build on the triple aim there for the patient-centered medical home. But you don't need to go south of the border to hear about patient and family-centered care. The Canadian Foundation for Healthcare Improvement has been talking about patient and family-centered care, spelled that away, has been talking about this with great passion and very articulate ways, talking about improving the patient experience and outcomes. Some very, very well done publications asking this question: what if patient experiences guided quality improvement and organizational change? What would that look like? What would that feel like? And one of the things, you're going to get a lot of ideas here, and you're going to get really excited about what you're doing. And I read the posters, and they're phenomenal. Make sure you spend time with each of those posters. They're really, really excellent. So one of the things to monitor then is what happened because we partnered with patients and families. That's great. But I'm going to invite you to monitor something else too. What would have happened if we hadn't partnered with patients and families? What would this process have looked like if we hadn't asked? What would have been the missed opportunity if we hadn't had that collaboration that we had? Try and capture that in the work that you do as well. What if patient experiences guided quality improvement and organizational change? And also the Canadian Foundation for Healthcare Improvement has some very nice pieces on ingredients for successful patient engagement, strategies for recruiting people. How do you partner? How do you work with them? We have those sorts of things at the Institute for Patient and Family-Centered Care. We don't have a monopoly on that. Lots of folks have lots of experience. Learn from them. Quality is more than technical quality. And the patient and family experience can be a driver for quality improvement. You know, for most clinicians, for very good doctors, for the people here who are working in professional roles, 98% of our time is spent on this. What is the problem? How can it be diagnosed and treated? That's what we feel like we know how to do. That's what we've been trained to do. And that's what we believe our patients and their families want from us. A good doctor is going to do that. But a complete clinician knows that patients and families, yes, care passionately about what's the problem and how can it be diagnosed and treated, but they are equally interested in how can I contribute to the process to enhance the quality and safety of care, which means when and where and how are we going to communicate, and will you listen? A complete clinician knows that every patient and family member wants to know, what does this mean for my family's life? What does this hospitalization or spell of illness or condition that I've come to your office for, what does it mean for my family's life? What's the plan? How are we going to continue care at home? If we're going to provide outstanding care always, we need to always be considering all 4 of these points. What's the problem? How can it be diagnosed and treated? How can our patients and families contribute to the process to enhance the quality and safety of care? What does this mean for them and for the life of their family? That's what KGH is talking about when it talks about a community and vision and strategic directions and transforming patient experience through a relentless focus on quality, safety, and service interprofessionally with patient-oriented research, and also when it talks about increasing the focus on complex acute and specialty care, delivering that better with better outcomes by partnering with patients and families. That's what we talk about with these principles: respect and dignity and information and participation and collaboration. And you may notice that much of the stuff that's in the literature talks about patient-centered care. And I guess if there was something I'd change in that great IOM report, it would be this: it's patient and family-centered care. Why? Because social isolation is a hugely powerful risk factor. And people have connection to somebody. Most do. And especially those who are most dependent on our hospitals and health systems for care, they definitely depend on others in their care. Families are in this too. And if there's anything that we know, if we know that social isolation is such a powerful risk factor, this is a study that showed that if you take people who have comparable conditions and you hold all sorts of things equal in the way that good researchers do, and then you look at their social connectedness, they have a 50% increased likelihood of survival for participants with stronger social relationships. That's pretty potent stuff. And so if we know that social isolation is a risk factor and social connectedness is a positive factor for better outcomes, if we know that, then certainly in our health systems we should be promoting personal connection to others, not inadvertently finding ourselves getting in the way of it. And that means recognizing all of the range of culture too that is there and how that plays into the care that we provide. Now, when we talk about family, we mean a lot of different things. Here's Statistics Canada says, what's a family? Well, a census family in Canada is defined as a married couple and children, if any, a couple living common law and children, if any, or a lone parent of any marital status with at least one child living in the same dwelling. Statistics Canada says a couple may be of opposite or same sex. All members of a particular census family live in the same dwelling. It's all about geography. That's who a family is. You live together, you're a family, okay? Here's one of the health systems in the US, and they say the Memorial Health System recognizes that the term family has many meanings. It means not only bonds created by marriage and common ancestry, but also bonds created by close friendships, commitments, shared households, shared child-rearing responsibilities, and romantic attachments. It's a nice definition of family. The Christ Hospital in Cincinnati, Ohio says, the word family refers to 2 or more persons who are related in any way, biologically, legally, or emotionally. Patients and families define who is family to them. And clearly that's what we're talking about when we talk about family. Here's my favorite definition. A family is a group of people who make an irrational commitment to each other's well-being to the point of making each other crazy. This is my family, okay? And Bronfenbrenner, when he said this, was really an astute clinician because, you know, it's who has that irrational commitment to each other's well-being that counts. I see that as clinically very important. I want to know who's connected to who and who makes a difference in your life. Who's going to be there when you go home from the hospital? Who's going to be there to help you if you're not getting along real well one way or another? And yes, there's going to be some craziness in there. That's all right, because social isolation is a risk factor and social connectedness improves outcomes. So as a clinician, I'll tolerate a little bit of mischief in there if it's going to get better outcomes for patients. That's what we're talking about. So it's talking about patient and family-centered care. Sometimes it helps to think about what patient and family-centered care isn't. And so we talk about driving forces in healthcare that tell us why are things the way that they are. So first we might talk about a system-centered driving force. This has been pretty traditional. The priorities in the system and those who work within it drive the delivery of healthcare. Why are things the way they are? Because it works for us. That's why. Not that we don't care about patients, but we're the ones at the table saying, yeah, I think this will all work better. And so that takes everybody in their individuality and kind of just push them through the system, and out they come kind of like widgets in this artist's conceptualization of what system-centered care might be. Or we might say we're going to focus on our patients. And I'm not here to be the language police, but mark what this definition is. The patient is the focus or unit of care interventions. Things are done to and for that patient instead of with the patient, and the patient is not viewed in the context of family or community. So here it's all about the patient, but the people caring for the patient, holding the strings, they're not really communicating. The family, the friends, the spiritual life of that person, well, they're just little blips up there. It's all about the patient. We're focused on the patient. Or maybe we're focused on the family. While the family is the focus or unit of care, interventions are done to and for them instead of with them. And so that puts the family sort of under the magnifying glass or under the microscope. We're all looking in at them. How you doing down there, family? But they're not interacting and relating to us. And that drives some of the way that we deliver care, doesn't it? It really does. We care about them, but are we working collaboratively with the family? And that's really what patient and family-centered care is. That's that driving force. The priorities and choices of patients and their families drives the delivery of health care. And I bet you're waiting for me to give you a beautiful illustration of what that looks like. And here it is. It's your canvas to create. It's why it's different at the University of Wisconsin or at Georgia Regents or at KGH or at North York or wherever it's going to be. It's different because it's going to be collaborative with your patients and families. I can't give you patient and family-centered care in a box. I can't just say, here, do this, and now you've done it. That's not the way this works. It's a collaborative and iterative process. It's one, oh, I said process. I think I'm supposed to say process here, aren't I? Sorry. So it's a collaborative and iterative thing. And that's what has to happen, is that you're going to work together with the patients and families in your setting. And they're going to help you create what that illustration looks like in your setting. But the core point is this, and Dale said it as well. Patient and family-centered care is working with patients and families rather than doing to and for them. And that is a profound shift in the way that care is delivered. And I want you to mark this point clearly. Patient and family-centered care is not just being nice. Now, being nice is good. We are pro-nice. We're all in favor of nice. But when we talk about patient and family-centered care, we're talking about a direct and intentional effort to unequivocally, mark that word, unequivocally, you can't miss it, communicate to patients that they are viewed as distinct and valuable individuals with a family and a place in the community, and that relationships between patients, families, and providers are essential alliances and partnerships, with each bringing expertise to decision making. That's what we're talking about. There's a story that is said to come from the Native American tradition. And it's a story of a wise elder and a child. And the wise elder tells the child that every day that elder experiences a struggle in his heart between two wolves, a kind wolf and a vicious wolf. And the child says, which one wins? And the elder says, whichever one I feed. What we're talking about here is feeding the kind wolves in our hearts, isn't it? Yes, it is about being nice, but we have to have the structures, we have to have the things in place that let that strength happen every day. That's what it means to have a culture. That's what it means to have a system. We're feeding that kind, good wolf that is the inclination of everyone you work with. Because, you know, you're going to go back and you're going to talk about patient and family-centered care, and they're going to say, well, I do that because I care. I care about patients and families. But is it unequivocal Is it something they can't miss? Do they experience that respect and dignity and get the information and feel it and feel like they're participating and collaborating? That's really the question. It's not always easy. To practice medicine with good spirit does not mean to be in a place where there's no noise, trouble, or hard work. It means to bring your calm and loving heart right into the midst of it. That's collaboration at all levels: the care of the individual patient, program planning and evaluation, and the policy level. It's about partnership. Now, I'm not suggesting that you do this with your patients, okay? This is not what I'm telling you to do, okay? But this was 1999, the BMJ, British Medical Journal, 1999, talking about embracing patient partnership. And they used tango as the metaphor of this incredible synergy that happens between those providing care and those receiving care, and what that means and how you make that happen. So yes, that's a real opportunity, and yes, don't do that, okay? To write prescriptions is easy, but to come to an understanding with people is hard. Franz Kafka wrote this in 1916. If you've never read the story, or if you haven't in a while, A Country Doctor, it's a wonderful story. And this is really what we're talking about today. It's not all about the technology and the meds. It's about coming to an understanding and balancing that together. Collaboration, to co-labor, to work together. That means that no one interest group is always right. It means taking what you think and what I think and what someone else thinks and coming up with something that works for everyone. Here's another definition of collaboration: an unnatural act between non-consenting adults. We don't always do collaboration so good, right? That's not something that we're exceptional at in our healthcare systems. And you know, there's this temptation that people have to say, oh wow, patient and families on committees and collaborating with us and working, you know, we don't do so good getting along with each other. We don't want them to know that. You know, maybe we should try and get our act together and then we'll invite them in. Guess what? They know. They know that we don't always collaborate so well among ourselves. And often it is, in fact, the presence of patients and families at the table that catalyzes improved collaboration. What does that look like? Well, at the Dana-Farber Cancer Institute in Boston, it's participation at all kinds of levels of the organization: advisory committees and education committees and clinical care and quality and safety and peer support and advocacy. The patient and family advisory councils at Dana-Farber, where they've been doing this for a very long time, they have members of councils as well as other patient and family members sitting on 93 different hospital committees. Now, I am daunted by the fact that there are 93 different hospital committees. So there's that, let alone that there are patient and family members on them. But again, you don't need to go south of the border to find this kind of partnership happening, because people understand what they understand at Dana-Farber Cancer Center, which is you'll never develop true patient and family-centered care by using patients and families merely as focus groups. So what do they do at Kingston General? Well, they've got patient and family advisory councils, and at least as I read it on the website, in total there are now 344 opportunities across the organization where patient experience advisors are partnering with staff to improve the patient experience. That is stunning. That is stunning. That's a remarkable change of culture. And I did see in one of the posters in the back that when we look at the patient experience advisors and what they're doing, they're on about 64 committees as of the time of that poster. Maybe it's 93 by now. But that's what it means to really infuse the voice of patients and families throughout your organization. Or go to Chatham and hear what they're doing. They've been working on this for the last decade or so, doing some really nice things. And you know, language does tell us things. So what did they say in their strategic direction 2007-2009? We will provide safe, quality, patient and family-centered care. Very nice statement. I agree with that. But they revised it after they had just a little more experience with their patients and families. And now what they say is, we will partner with patients and families in the delivery of safe, quality care. Did anything really change in what they're doing? I don't know. Is it unequivocal when you read that second one, how they go about that compared to the first one? Yes. That unequivocal is really key. It takes the voice in the eye of the patient to see is that really what you mean? Is that what you're saying? And can we hold you to that? And that provokes that change in language. What are they doing there? They're doing similar things. They've got an executive sponsor for PFCC. They've got a full-time coordinator. They've got advisors serving on steering committees. They've got people on all kinds of committees in that setting. And they've got a grateful CEO who knows that the care is better because of that partnership. Or in Calgary, I was in Calgary a couple months ago, and they've just opened their South Health Campus, really quite a stunning facility, and there a family leader was appointed as project manager for partnerships and citizen engagement, and helped them to really develop all of the principles and premises of that setting. They too have a citizens advisory team, and that team gets together and is continuing in many, many ways to guide the further evolution of that facility and of the care that's delivered in it. So they've partnered to assure input, and they've helped especially with the waiting room experiences and design and how things are structured. They've got a set of commitments for the cancer, for the center, for the campus that are making a difference. And they've shared stories of patient and family experiences with the health system. Storytelling is positive. A phrase I like is that the plural of anecdote is data. If you hear one story and then you hear another and another and another, you know, we used to dismiss, oh, that's anecdotal. But if you hear it again and again, that's data. That's telling you something. Sharing stories makes a difference and changes the climate and culture of care. How about Saskatchewan? I had a chance to be there a few years ago to work with the ministry there as well. And in Saskatchewan, it's the patient first review for patients' sake. It's talking about patients first as really being the policy of the province. And the recommendation out of the review that's been adopted is that the health system make patient and family-centered care the foundation and principal aim of the Saskatchewan health system through a broad policy framework to be adopted system-wide, developed with patients, families, providers, and health system leaders, a policy framework that serves as an overarching guide for healthcare. That's what the patient-first philosophy is about in the province of Saskatchewan. Excellent work. What are they working on as their core concepts? Dignity and respect, information sharing, participation and collaboration, the essence of delivering high quality, high safety, best practice health care in that province. And they're doing it with lots of partners. And I'll add to the fact that one of their advocates and partners is the Saskatchewan Union of Nurses, as well as the Medical Association. And so that's been a powerful partnership for good as well. British Columbia, the Patient Voices Network is an essential component of Patients as Partners initiative. Nothing About Me Without Me, which comes from the IOM report. And they're talking about how do you get patients more involved. And the Patient Voices Network that they've developed in British Columbia is really thoughtful because it's a way of making province-wide sort of what happens institution by institution in some provinces, making it available anywhere and even virtually to get patient input in care. You know, it sounds like a big thing, but it looks like this. At Ocean Park Health Center in San Francisco, it's just a bunch of people who go to that health center, coming together, having lunch, and talking about care and improving the care process. Lisa Golden, who's the medical director, says, look, these members, they've been enthusiastic and interested in improving care of patients and outreaching to the community, and she feels energized and revitalized by working with them and improving care processes in partnership. It looks like this. It looks like the DVD divas who created a patient safety video. Your safety, your meds, your medical visit. And when you see that, you realize that if that had been created by thoughtful, smart, well-intended healthcare professionals, it wouldn't have looked the way it looks when the production that these two women put together. But this speaks so clearly to the real lived lives of patients and helps them to think about how they're going to gather their meds up and bring them to a clinical appointment so that everybody's on the same page. What does it look like? It looks like this at what used to be called the Medical College of Georgia, and then Georgia Health Sciences University, and now Georgia Regents University, and you'll hear from our good friends there who are doing just tremendous things. But you know, when they do a building project there, people have to sign off, and infection control signs off, and environmental services, and IT signs off, and a patient advisor and family member must sign off on every redesign, remodel building project there. Why? Because it's better when they're involved. Things just come out better. What does it look like at the Vanderbilt University Medical Center? It looks like a patient handbook that says every patient, every time, says we're going to check your ID, wash our hands, explain everything, always listen and invite questions. And we're going to tell you, as patients who experience care here, how things work, what is important, what can happen. Speak up, be a partner, and do this. That's what patient and family-centered collaboration looks like. In a growing number of instances where truly stunning levels of improvement have been achieved, leaders of these organizations often cite putting patients and families in positions of real power and influence, using their wisdom and experience to redesign and improve care systems as being the single most powerful transformational change in their history. That's no small statement. So patient and family-centered care can look a lot of ways. It may be about understanding that patients and families are essential members. It may be about ways that people communicate about who they are. It's about families no longer being considered visitors or safety or other things. These are all practices that generally have come out in places that are real advocates for patient and family-centered care. But the key is creating a welcoming environment. We're in this together. We want families and patients to be part of the team. That's what they say at Pitt County Hospital in North Carolina. It's clear, it's unequivocal. And it's not just in the hospital. You know, in the hospital, what's happening many places is we're moving away from this idea that family members are visitors. You know, when I go home, I'm not going home to visit my wife, right? You know, I live there. We're a thing, okay? And so when you tell me if she's in the hospital that I'm going to visit her, no, that's not the way that it goes. I'm a partner in care. I'm important in her life. She's important in my life. And so increasingly, it's thinking about family presence and how do we support it. Why? Because social isolation is a risk factor. Connectedness improves outcomes. It's thinking about family presence instead of thinking about families as visitors. But it's not just hospitals. It's in the clinics too. You know, in my office, just like every other, you know, I've got my desk, I got my little computer, I can turn the screen, we can do it together. There are 2 chairs there. Now, one chair is for the patient, right, who's got the appointment. Now, what I ask my colleagues, what I ask other doctors is this: is that other chair your just-in-case chair? Or is that your I want you there chair? Meaning, bring somebody with you. I would welcome somebody. How often in our outpatient settings are we making that point? Unequivocally and explicitly. Bring someone else with you. I'm happy to have someone else here at this appointment. Let's have them here and let's make sure you're getting the support that you need and want. People always want the evidence, and there's lots of it. You can go to the Institute's website and find it. It's important and it's robust. St. Vince in my state of Wisconsin, the great football coach Vince Lombardi said, if you're not keeping score, you're just practicing. So we've got to keep score because we've got to test the model and know what's going on. So what are some of the examples of some of these outcomes? Patient safety. Here at the Dana-Farber Cancer Institute, when they went ahead and co-designed a medication reconciliation system, co-designed it, asked the question, what would have been done if the patients weren't there? The wrong thing. As it turns out, when you talk to those folks, they'll say it was the design impact of the patients and families that succeeded in a collaborative process resulting in a 90% reduction in medication errors. Nurse change of shift report at the bedside at Emory in Georgia, also improving care, reducing harm, reducing error, improving the patient experience. How about acute myocardial, now come on, heart attack? it does turn out in this study from the Veterans Administration system in the US that looked at about 1,850 patients, if you had your heart attack and got your care at a hospital setting that was more patient and family centered than another one, you had a higher chance of being alive a year later. Now, I'm not saying this was massive numbers, as they say. It was a significant, modestly lower hazard of death. I'll take a modestly lower hazard of death. That's fine with me. If I'm in a patient and family-centered setting, I have a higher chance of being alive after a heart attack. That's pretty cool. How about in rounds? Hospitals are all about rounds. Rounds are changing too. How do we do rounds with patients and families in partnership? Cincinnati Children's Hospital has been a real national leader of this, although places all over the country. Writing of orders, decreased errors 7 to 9% to 1% when done collaboratively with patients and families and interprofessionally with other staff present at the same time. Improving safety, improving quality, improving care. There was no downside. Rounds took a little longer. Uh-oh, is that a problem? No, because they got so many fewer callbacks that the net gain in time was actually positive for them. Or how about resource utilization? Here in Contra Costa, California, they were dealing with people with severe and persistent mental illness and did a value stream mapping event about the way that behavioral health emergency care happened. And they included those people who had experienced behavioral health emergencies and family members and law enforcement and ambulance drivers and all sorts of people, and they got them together. And they said, how can we do this better? And what happened? Things got better. They reduced by 50% the number of people who left the ED prior to getting care, which means they enhanced people's access to care. What did they do? They figured out a way to keep people out of the ER and get them right to the mental health services they needed while being able to identify those people who did need to have a medical evaluation. That saved space and time in the ER. That improved the care in the mental health setting. Who did that? It was the voice of the consumers and families, they will say, that made the difference in that care. Or in outpatient care. This study was done in 2000 here in Ontario, Western Ontario, by Moira Stewart, who found that when patients achieved common ground with physicians, health status improved, emotional health improved, fewer referrals and diagnostic tests were needed 2 months after the visit. Well, it was repeated in a big way in 2011, where this is an amazing study. 509 patients, they videotaped every interaction with the primary care doctors and broke them down into 15-second segments and scored whether there was a patient and family-centered thing going. I think about how many grad students were fed on that study. It was a very good study. Nicely done study, though, to do that. What did they find? Higher patient-centered care was associated with significantly decreased use of specialty care, hospitalizations, lab, and diagnostic testing. It cut costs for the next several months by 50%. That's a pretty powerful intervention when you're talking about things. Here's another one that just talks about, this is a study Judith Hibbard published recently, predicted per capita cost of patients by patient activation level, and the lowest level activation, that is people who are the least connected to and involved in their care, had a statistically significant higher cost of care than people who were engaged and involved. So if we're talking resource utilization, that's pretty important, and that affects the way we do primary care as well as specialty care. Or how we do care management. This is a study, and again, it's a different healthcare system, but we're all thinking about how to save resources. This one done in California found that if they did case management for people with complex chronic illnesses, where the premise of the case management was, what are your goals and what do you want, as opposed to us telling people, here's how we're going to help you, what happened? Well, outcomes were the same in terms of people living and their health status, but costs went down. And people reported that their quality of life was improved because it was meeting their needs in a collaborative way. Quality and safety being better. Again, in the U.S., we have our care systems where we look at how care is provided and what does it mean to do quality. And Memorial Health System is a system in Florida that has made patient and family-centered care the basis of everything that they do. And their care outcomes are among the best in the country. And just like we said was being done across Canada and across the U.S., they have patient and family advisors involved in all sorts of elements of the care experience there. But again, you don't need to go to Florida for that. Go to Thunder Bay. I've been there, and they're doing some pretty interesting things. And in Thunder Bay, they think big. Their vision is to lead world-class patient and family-centered care. World-class. Their mission is to advance world-class patient and family-centered care in an academic and research-based acute care environment. And they are doing it with great alacrity. They have people involved in all levels of the care experience, and in their senior corporate management system, they have patient and family advisors deeply connected to many things they do. They have advisors on 77 committees, teams, and work groups. I don't know if everybody counts them all the same, but they're very involved in what they do, just like they are here. Lucian Leap and Don Berwick and Carolyn Clancy and Jim Conway published an article together where they say, we envision patients as essential and respected partners in their own care and in the design and execution of all aspects of healthcare. In this new world of healthcare, organizations publicly and consistently affirm the centrality of patient and family-centered care. There's that unequivocal again. They seek out patients and listen to them, hear their stories and are open and honest with them, and take action with them. The family is respected as part of the care team, never visitors, in every area of the hospital. Patients share fully in decision-making and are guided on how to self-manage, partner, and develop their own care plans. They are spoken to in a way they can understand and empowered to be in control of their own care. That's what we're talking about. That's what you're going to be working on over the next day. How does that vision happen? Every patient, every time, outstanding care, always. How do we make sure that happens in the strategies that we each bring at our institutions to improve quality and safety? Patient and family-centered care is not just a catchphrase or a vague concept. Rather, it's a tangible model of care, including initiatives, processes, principles, and the tools to do the job. It means we don't just treat the patient, we engage our patients and their families in the care process. They demand it of us, and we demand it of ourselves. That from Joe Mappa at Mount Sinai, and that's, I know, part of what you're talking about here. I hope I've helped you look at the healthcare that you're a part of with maybe new glasses. And, you know, we all know kids, and kids are pretty cute, and sometimes they can teach us a lot. So I just want to finish up by sharing with you the toddler property laws, because kids see things in a certain way. So think about a toddler in your life. And how does a toddler view the world? Well, they would say, if I like it, it's mine. And a toddler would say, if it's in my hand, it's mine. And of course, to a toddler, if I can take it away from you, it's mine. A toddler would say, if I had it a little while ago, it's mine. Or, if it's mine, it must never appear to be yours in any way. And of course, to a toddler, if I'm doing or building something, all of the pieces are mine. Or even if it looks just like mine, it's mine. To a toddler, if I saw it first, it's mine. Or if I think it's mine, it's mine. But of course, if it's broken, it's yours. Our healthcare systems are all of ours. They're all of ours to share, all of ours to partner in, all of ours to collaborate in. There are systems that are doing amazing things. We shared examples. There are principles that really help you do the job. We talked about them. There are examples that come from the heart and the mind and the experience. There's remarkable collaboration happening. And we still have that open canvas as to how we make it better. So I appreciate your kind attention, and I look forward to partnering with you over the next day as we create the next step in our vision. Thank you very much.